Hello, my name is Graham McLaren. Thank you very much to the conference organisers for the invitation to speak. I have been asked to present the con argument against Ecmo in septic cardiomyopathy. So before we continue, this is a review article that is so recent it's not even in print yet. It's just been published online, and this is in Nature, so it has a degree of authority to it. Mervyn Singer, the senior author, of course was in the Sepsis 3 panel, so clearly a senior figure in the world of sepsis. And these are some of the comments that they've made lifted straight out of the review. From the outset, the study of myocardial dysfunction in sepsis was fraught with puzzling and contradictory findings. Here we have a comment about the epistemological challenges, that there's a lack of consensus again about the definition. And in the concluding paragraphs, they say this field has been challenged by a lack of uniformity in its definition. So in fact, we really don't know what we're talking about when we talk about septic cardiomyopathy. We may each have vague impressions of what it means, but we haven't come to an agreement as to what the entity actually is. So instead of talking about septic cardiomyopathy specifically, let's just take a step back and talk about Ecmo in septic shock, and specifically in adult septic shock. I'm not going to be talking about pediatrics for this talk. So here is one of many studies showing similar results. 32 patients, nearly half of them had had a cardiac arrest before the initiation of Ecmo. And of course, if a cardiac arrest is not a manifestation of a septic cardiomyopathy, then what is? And only about 1/5 of the patients in this Korean study survived to hospital discharge. Here we have a study from Taiwan, similar results. 1/4 of these patients had cardiac arrest before being cannulated. Less than 1/3 survived to hospital discharge, and only 1/5 survived to hospital discharge without any form of neurological injury. If Ecmo was initiated for septic shock after 30 hours, then no patient survived. So these are not particularly encouraging results so far, acknowledging that these are patients with different hemodynamic manifestations. Some of them may have had distributive shock, but nonetheless a substantial portion had a cardiac arrest. Here's another Korean study, the most discouraging one so far. 71 patients on VA Ecmo, specifically for septic shock. Only 15% were weaned off Ecmo. Only 7% left hospital alive. And on follow-up, a minimum of 6 months later, only 3 out of those 5 were alive. So in this study, the use of Ecmo for adult septic shock was associated with less than 5% survival. That doesn't sound very good to me. Here's a more recent study, and this one comes from London. So we've moved out of Asia, and we're now in Europe. This is a small study, much smaller than the others, only 12 patients. Nonetheless, we had 75% survival, and they used VAV Ecmo in order to achieve these goals. And of course, here is the work of my esteemed colleague, Dr. Brechot, a study we all know, 14 patients over 4 years, all with severe sepsis-induced cardiac depression, however we choose to define that. And in this study, the majority of patients survived. But wait a minute, you may note that this study came from La Pitié-Salpêtrière Hospital in Paris. That is the biggest Ecmo center in the world. They do more than 400 cases a year. More recent times, they've probably done more. Only 14 patients had this clinical entity over a 4-year period in the biggest Ecmo center in the world. So what we're talking about here is something that's extremely uncommon. And here's another European study, this time from the Karolinska Institute in Stockholm. Again, these patients were looked after in a dedicated Ecmo intensive care unit. 37 patients, some with distributive shock, some with septic shock, and left ventricular failure, and outcomes seemingly very good. But if we go into the details here, so all of them fulfill the sepsis 3 definitions, so that's a good start. But in order to go on Ecmo in this study, they needed at least one of several criteria, one of which was a mixed venous oxygen saturation of less than 55%. Now, to me, that's not an indication for Ecmo. That's an indication to consider whether or not the patient needs more fluid or more inotrope. Other criteria included a high lactate and a high vasoactive inotrope score of more than 50. But again, a lot of these patients will be managed in non-Ecmo centers with perfectly acceptable outcomes without the use of Ecmo. Another concern about this study is that, contrary to almost every other study looking at the difference in cannulation strategies, these patients did much worse with veno-venous Ecmo. Long-term mortality was assessed at least 6 months after hospital discharge. 70% of the patients who had VV Ecmo were dead, and only 30% of the veno-arterial patients, which raises questions about why that might be the case and whether this is really easily generalizable to other settings. Perhaps they were doing things in the center which are not common practice elsewhere. So instead of looking at single center studies, let's step back a little and look at the real world. This is a oft-quoted study, the SAVE study, published in the European Heart Journal by one of Dr. Brachot's colleagues, Matthew Schmidt. And we can see in the group that were taken from the ELSO registry, 317 patients put on ECMO for sepsis, and 37% survived. So they're not in centers in Asia, they're not in centers in Europe, they're taken from the ELSO registry, can be anywhere, predominantly North America, of course, and less than half of these patients are surviving. We don't know the hemodynamic pattern of shock prior to cannulation, but nonetheless, this is not so as encouraging as the studies we've just reviewed from Europe. Moving away from individual studies and moving towards guidelines, do we have any recommendations about the role of ECMO for septic cardiomyopathy in adult patients from guidelines? Well, here I do quote a pediatric guideline. This is the American College of Critical Care Medicine paper that came out in 2017. You can see the treatment algorithm is very clear, and at the end of that time, if nothing else works, then there is a recommendation to use ECMO. This was subsequently supported in the 2020 Surviving Sepsis campaign. The first ever pediatric Surviving Sepsis campaign guideline came out in February last year, and they did scrutinize the use of ECMO as rescue therapy for pediatric septic shock. And again, it was a recommendation, albeit a weak one, with low quality of evidence. Let's see if that's replicated in the adult surviving sepsis guidelines. So here we have those guidelines and questions, and ECMO is not mentioned once. So is it because the entity is so rare, or is it because it seems strange to be using mechanical circulatory support for a condition that's generally characterized by a high cardiac output and only very rarely by a severely impaired ventricular failure? This is a summary of some of the studies that I've talked about, the uncontrolled case series in adult septic shock. We can see that the survival is vastly different. So different, in fact, it makes you think whether we're talking about different patient populations. How can one disease and one treatment have 7% survival in one center and 75% in another? It suggests that we're not comparing the same disease entity. So at last we come to the only controlled series, to my knowledge, in adult septic shock with the use of ECMO, which was published in The Lancet last August. The first author was Dr. Brachot, and at face value, these findings are very encouraging. They had 82 patients with what we could call a septic cardiomyopathy versus 130 controls from culled from 3 French intensive care databases, and both adjusted and unadjusted survival were significantly higher in the Ecmo group, even though the Ecmo patients had greater severity of illness, higher inotrope doses, and worse organ dysfunction. So 90-day adjusted survival, 51% in the Ecmo group and 14% in the non-Ecmo group, with an adjusted relative risk of 0.57, albeit with relatively wide confidence intervals. So how did they define septic shock in this study? Well, they defined it as either a left ventricular ejection fraction of less than 35% or a cardiac index of less than 3. They had hyperlactemia was a feature of it, as was relatively high vasoactive inotrope scores. And even though this study was published in The Lancet, that didn't mean that it was completely free of problems. One of those problems might be seen as the pre-ECMO cardiac arrest risk, which was 13% in this study. You'll recall some of the earlier studies from Asia, that risk was as high as 45%. Another problem was that the control group were not necessarily taken from the author's institutions. They were taken from a multitude of other institutions, taken from 3 ICU databases. So we don't know much about the staffing and the quality of care provided in those other institutions. The treatment group, of course, were supported in some of the busiest ECMO centers in the world. And whether we can extrapolate those findings to other settings is open to question. And another issue, of course, is whilst we have lots of good intensive care data, I think we have insufficient granularity about non-ECMO, non-hemodynamic care. We don't know, for example, how appropriate the antibiotic use was in the patients being treated for septic shock. We don't know how effective the source control was. So there's a lot of potential confounders here. Now, the authors attempted to address this by using a variety of statistical techniques, but of course, it's not as good as a randomized controlled trial. And I think the confounding does remain an issue in this study. However, superficially impressive its results are. So in conclusion, I was asked to discuss the role of, or argue against, using ECMO for septic cardiomyopathy. It's very difficult to argue for or against anything if we can't agree what it is. What we need is a consensus definition that has been validated. And until we get that, it's going to be very difficult to continue this discussion. And you will notice the published survival rates using ECMO for septic shock in adult patients ranges in the literature from 7% survival to 90% survival, which it's clear that this is a problem of definitions, of trying to compare different institutional practices. And the absence of any comment in the surviving sepsis guidelines about the role of ECMO in adult septic shock speaks volumes, both about the rarity and the lack of evidence. Lastly, the only studies which do appear to support the use of ECMO for this entity known as septic cardiomyopathy come from high-volume dedicated ECMO centers in Europe. Now, that may be evidence that they're providing better care than other centers can do, or it may just be that they have a lower initiation threshold to ECMO. You all may be familiar with the cognitive bias known as Maslow's hammer, which is that if all you have is a hammer, then everything looks like a nail. And it may be in non-ECMO centers, clinicians are perfectly capable of dealing with septic cardiomyopathy without using ECMO and have good results. The fact is, we don't know. Thank you very much for your attention.
Thank you very much, Graham, for this very nice talk. Thomas, I think it's now time for a discussion.
Yes, we actually have